Hey everybody, it's time for a respiratory CCRN PCCN question for today. All right, so all of the following are classic characteristics of acute respiratory distress syndrome, or ARDS, except, well, A, decreased PO2 FiO2 ratio. We just call that PF ratio. That's A. B, refractory hypoxemia. C, increased pulmonary arterial occlusive pressure, also known as wedge. And then D, normal heart size on chest x-ray. Take a moment and think about that. Well, the answer here, guys, is C, increase in pulmonary artery occlusive pressure. So let's go through each one of these. Now, why do we see, as a classic sign, a decreased PF ratio? Remember, we get that number by taking the patient's PO2 and dividing it by their FiO2. And in order to divide by a percentage, remember, we have to take that FiO2 percentage and we have to convert it over into a decimal. So, for example, if we're taking you and I, so we have a PO2 of 95%, and we're figuring out our PF ratio. 95% divided by the air that we're breathing, the amount of oxygen, the FiO2 that we're breathing, that's room air, right? That's 21%. To convert that into a decimal, it would be 0.21. And so you would find that, if you were to figure out, given a normal PO2 on room air, you would see that our PF ratio is in the 400s range. All right, so decreased PF ratio indicates an intrapulmonary shunt. And we expect to see then that PF ratio drops and drops. In fact, when you look at some of the criteria for ARDS, you can see that, severe, associated with a very low favorable outcome, or I should say a high mortality rate, patients have a PF ratio less than 100. And so we can determine overall outcome by looking at the degree to which the PF ratio is affected. All right. So that we would expect to see. Refractory hypoxemia. Oh yeah, that is an expected finding, a classic finding. In fact, it's refractory hypoxemia that would make us consider ARDS. And what refractory hypoxemia is where you're going up and up and up on the patient's FiO2 all the while they're not getting better. Once again, reflective of a right to left intrapulmonary shunt, where blood is leaving the right side of the heart, making its way back to the left side of the heart without ever getting fully oxygenated. Now, I'm just going to skip down just for a second because this will make sense in just a moment. D, normal heart size on chest x-ray. This is what helps us differentiate a non-cardiogenic pulmonary edema, like ARDS, from a cardiogenic pulmonary edema, like left-sided, decompensated left-sided heart failure. Because when we're talking about left heart failure, of course, we have an increase in left heart size. So if the heart looks of normal size, then we're kind of looking like, we're not talking about left-sided heart failure here. And so we would not then see an increase in pulmonary artery occlusive pressure, also known to be what? Wedge pressure is what we call it. Wedge pressure represents left ventricular filling. And we would, we don't have an increase in heart size, we don't have a left-sided failure, so we would anticipate our wedge pressure or pulmonary artery occlusive pressure to be normal. So the answer to this question is C. That is not the finding we would expect to see in ARDS. Hope you like this question. Come and visit me on my website, khoppypresents.com, and I'll see you again tomorrow. Bye-bye.